Arterial blood gas interpretation often looks intimidating at first. Lots of numbers, lots of confusion. In this video, we're going to break ABG interpretation down step by step in a simple and logical way, exactly how you would approach it in the ICU or in exams. We will start with validating the ABG, then move on to interpretation, compensation, anion gap, and finally work through real clinical cases. By the end of this video, you should feel confident reading any ABG without panic and without guesswork. Let's begin. So before we learn how to interpret an ABG, it's important to understand why do we do an ABG in the first place. First, ABG helps us diagnose acid-base disorders, which allows us to differentiate whether the problem is metabolic or respiratory. And very importantly, it helps us identify mixed disorders, which are commonly missed. Second, ABG helps us assess oxygenation by looking at values like PaO₂, the alveolar to arterial gradient, the PF ratio. We can objectively assess how well the lungs are oxygenating the blood. Third, ABG helps us assess ventilation. The PaCO₂ tells us whether the patient is hypoventilating or hyperventilating, which is especially important in patients on mechanical ventilation. ABG also plays a major role in guiding treatment, whether it's adjusting ventilator settings, deciding on fluids, bicarbonate therapy, or bronchodilators. In critically ill patients like those with shock, ARDS, sepsis, decay, or trauma, ABG becomes an essential monitoring tool. And finally, an ABG helps us validate the clinical picture. The numbers should always make sense with the patient's vitals and overall condition. If the ABG does not fit the story, we should always pause and suspect a possible error. So, what exactly is an ABG? An arterial blood gas is essentially a snapshot of the patient's acid base status, oxygenation, and ventilation at a given moment in time. It gives us multiple key parameters, including pH, PaCO₂, PaO₂, bicarbonate, oxygen saturation, and often lactate. When we interpret these values together, an ABG helps us assess three major things: lung function, metabolic status, and tissue perfusion. That's why ABG interpretation is such an important skill, especially in the ICU and emergency settings. Before interpreting any ABG, the very first step is validation. We need to confirm that the sample truly represents arterial blood and that the values are reliable. The PaO₂ should be appropriate for the given FiO₂, and the oxygen saturation should make sense in relation to the PaO₂. These values should correlate with each other and with the patient's clinical condition. If the sample is venous instead of arterial, the PaO₂ will appear falsely low and the PaCO₂ may be higher than expected. So, before analyzing acid base status or ventilation, always pause and make sure the ABG itself is valid. The next step in ABG validation is to check whether the pH matches the hydrogen ion concentration. Remember, pH and hydrogen ions have an inverse relationship. Lower pH means a higher hydrogen ion concentration, and a higher pH means fewer hydrogen ions. As a quick bedside reference, a pH of 7.40 corresponds to a hydrogen ion concentration of about 40 nanomoles per liter. For every zero point 0.1 decrease in pH, the hydrogen ion concentration increased by approximately 1.25 times, and for every zero point 0.1 increase in pH, it decreases accordingly. If the pH and hydrogen ion concentration do not correlate, the ABG may not be valid, and the results should be interpreted with caution. The next step in validating an ABG is to assess internal consistency. The values of pH, PaCO₂, and bicarbonate should make physiological sense together. These variables are linked. They should move in directions that are logically consistent. For example, if the pH is low, there should be a clear reason for that acidemia, either an elevated PaCO₂ or a reduced bicarbonate. If the numbers don't seem to talk to each other or the pattern doesn't fit basic physiology, we should always pause and suspect a possible error rather than forcing an interpretation. The final step in ABG validation is clinical correlation. An ABG should always fit the patient's vital signs and overall clinical story. The numbers must make sense in the context of how the patient looks at the bedside. If the ABG findings do not match the clinical picture, we should not ignore that mismatch. Instead, we should consider a sampling or analytical error. In such situations, it's often safer to repeat the ABG rather than base clinical decisions on potentially inaccurate data. Now, let's look at a quick and practical way to estimate hydrogen ion concentration from the pH. We use what's commonly called the rule of 1.25. For every zero point 0.1 decrease in pH, the hydrogen ion concentration increases by approximately 1.25 times. And for every zero point 0.1 increase in pH, the hydrogen ion concentration decreases by about 1.25 times. This is a very useful bedside rule to quickly check whether the pH and hydrogen ion concentration are moving in the expected direction, especially while validating an ABG. This quick reference table helps you rapidly correlate pH with hydrogen ion concentration. The key clinical use of this relationship is validation. If there is a mismatch between the pH and the expected hydrogen ion concentration, we should always suspect a possible ABG error. So remember, before jumping into interpretation, always take a moment to validate the ABG first. It's a small step, but it prevents major mistakes. The next part of ABG validation is the Handerson Hasselbach check. The core idea here is simple. The ABG values must obey the Handerson-Hasselbalch relationship, which links pH, PaCO2, and bicarbonate. This equation reminds us that pH depends on the ratio of bicarbonate to carbon dioxide, not on either value in isolation. We don't need to calculate this equation every time at the bedside. Instead, we use it conceptually to see whether the numbers make physiological sense together. If the values clearly do not fit this relationship, the ABG may be invalid, and it's safer to reassess rather than force an interpretation. In day to day ICU practice, we apply the Henderson Hasselbalch concept in a practical way rather than doing calculations. An increase in PaCO2 should lead to a fall in pH, and a decrease in bicarbonate should also lead to a fall in pH. These relationships should move in predictable directions. If both PaCO2 and bicarbonate are moving in the same direction without a clear explanation, we should pause and consider either a mixed acid-base disorder or a possible error. From a clinical standpoint, if the calculated bicarbonate does not match the reported bicarbonate, it's safer to repeat the ABG or suspect an analyzer or sampling error rather than forcing an interpretation. Another important part of ABG validation is confirming that the sample is truly arterial. A simple way to do this is by using PaO₂ FiO₂ relationship. On room air where the FiO₂ is about 21%, the expected PaO₂ should be roughly 80 to 100 millimeters of mercury. As a rough ICU rule, the PaO₂ is usually about 4 to 5 times the FiO₂. If the oxygen values are far outside this expected range, we should question the validity of the sample. These are also clues that suggest a venous sample, such as a low PaO2, a relatively high PaCO2, oxygen saturation that does not match the pulse oximetry reading, or an ABG that simply doesn't fit the clinical picture. In such situations, it's important to check and recheck the sampling technique and repeat the ABG if there is any doubt. An invalid ABG should never be interpreted or used to guide clinical decisions. Once we have validated the ABG, we can move on to interpretation using a stepwise approach. The first step is always to look at the pH. If the pH is less than 7.35, the patient has acidemia, and if the pH is greater than 7.45, the patient has alkalemia. The second step is to look at the PaCO2. A PaCO2 greater than 45 suggests respiratory acidosis, while a PaCO2 less than 35 suggests respiratory alkalosis. Next, we look at the bicarbonate level. A bicarbonate level less than 22 points towards metabolic acidosis, and a value greater than 26 points toward metabolic alkalosis. Finally, we decide the primary disorder by asking a simple question. Which of these chains best explain the pH abnormality? That becomes our primary acid-base disorder. Once we identify an acidemia or alkalemia, the next step is to decide whether the primary disorder is respiratory or metabolic. A simple rule helps here. If the pH and PaCO2 move in opposite directions, the disorder is respiratory. If the pH and bicarbonate move in the same direction, the disorder is metabolic. For example, a low pH and a high PaCO2 indicate respiratory acidosis, while a low pH with a low bicarbonate indicate metabolic acidosis. Similarly, a high pH with a low PaCO2 suggests respiratory alkalosis, and a high pH with a high bicarbonate point towards metabolic alkalosis. Using this rule helps quickly and reliably identify the primary acid-base disorder. After identifying the primary acid-base disorder, the next step is to assess whether there is an appropriate compensation. Compensation is the body's attempt to bring the pH back towards normal. In metabolic disorders, this compensation occurs mainly through the lungs, while in respiratory disorder, compensation occurs through the kidneys. There is one very important rule to remember. Compensation never overcorrects the pH. If the pH crosses into the opposite range, we should always suspect a mixed acid base disorder. The time course also matters. Respiratory compensation occurs relatively quickly, over minutes to hours, whereas renal compensation takes longer, typically hours to days. Keeping these principles in mind helps us judge whether the compensation we see is appropriate or whether another disorder is present. Once we identify the primary disorder, the next step is to check whether the compensation is appropriate using expected compensation rules. In metabolic acidosis, we use Venter's formula to estimate the expected PaCO₂ and assess whether respiratory compensation is appropriate. This helps us identify whether an additional respiratory disorder is present. In metabolic alkalosis, the expected response is respiratory hypoventilation. For every 1 milliequivalent per liter increase in bicarbonate, the PaCO₂ is expected to rise by approximately zero point 0.5 to zero point 0.7 millimeters of mercury. Comparing the expected PaCO₂ with the actual value helps us determine whether the compensation is appropriate or whether a mixed acid-base disorder exists. Now, let's look at the expected compensation in respiratory disorders, whether the kidneys adjust the bicarbonate level. In acute respiratory acidosis, the bicarbonate increases by about 1 milliequivalent per liter for every 10 millimeters of mercuric rise in PaCO₂. In chronic respiratory acidosis, which typically develops over several days, the renal compensation is stronger. Here, the bicarbonate increases by about 4 milliequivalents per liter every 10 millimeter of mercury rise in PaCO₂. In acute respiratory alkalosis, the bicarbonate decreases by about 2 milliequivalents per liter for every 10 millimeters of mercury fall in PaCO₂. And in chronic respiratory alkalosis, the bicarbonate decreases further by approximately 5 milliequivalents per liter for every 10 millimeters of mercury decrease in PaCO₂. Comparing these expected changes with the actual bicarbonate value helps us determine whether the compensation is appropriate or if a mixed disorder is present. Now let's talk about the anion gap. The anion gap is mainly used to classify metabolic acidosis. It helps us understand whether the acidosis is due to loss of bicarbonate or due to the presence of unmeasured acids in the blood. In simple terms, the anion gap represents acids that we do not routinely measure on standard blood tests. By calculating the anion gap, we can narrow down the possible cause of metacidosis and decide the next steps in evaluation and management.
The anion gap is particularly useful in specific clinical situations. We primarily use it in metabolic acidosis, where it helps narrow down the underlying cause. It is especially important in conditions like sepsis, DKA, and renal failure, where unmeasured acids commonly accumulate. The anion gap is also helpful when toxins are suspected, as certain ingestions can lead to high anion gap metabolic acidosis. So, whenever we encounter metacidosis, calculating the anion gap becomes an essential next step. Now, let's look how to calculate the anion gap. The formula is simple. Anion gap equals sodium minus the sum of chloride and bicarbonate. In most exam and clinical settings, potassium is usually ignored. The normal anion gap is typically between 8 and 12 milliequivalents per liter. A value greater than 12 indicates a high anion gap, while a low anion gap, which is less than 8, is relatively uncommon. It's also important to remember the effect of albumin. Since albumin is a major unmeasured anion, the anion gap decreases by approximately 2.5 milliequivalents per liter for every 1 gram per deciliter fall in albumin. Keeping this correction in mind helps avoid underestimating the anion gap in patients with hypoalbuminemia. Now let's look at high anion gap metacidosis, often abbreviated as HAGMA. The most accepted and exam-friendly way to remember the cause is the gold mark mnemonic. G stands for glycol, such as ethylene glycol and propylene glycol. O refers to oxoproline, seen with chronic paracetamol use. L represents L-lactate, commonly due to sepsis or shock. D stands for D-lactate. M methanol. A aspirin or salicylate toxicity. R renal failure leading to uremia, and K stands for ketoacidosis, including diabetic, alcoholic, and starvation ketoacidosis. A useful clinical tip to remember is that a high anion gap indicates the addition of acids to the blood. In the ICU setting, we should always look for lactate and ketones first, and these are the most common and immediately treatable cause. Now let's move on to the normal anion gap metabolic acidosis, also known as hyperchloremic metabolic acidosis. The key mechanism here is the loss of bicarbonate. To maintain electrical neutrality in the plasma, chloride rises. That's why the anion gap remains normal. Common causes include diarrhea, renal tubular acidosis, particularly the types 1, 2, and 4, excess normal saline administration, as well as pancreatic or biliary losses. Early renal failure can also present with this pattern. A useful clinical clue is the presence of a normal anion gap with an elevated chloride level. Recognizing this pattern helps distinguish bicarbonate loss from acid addition and guides further evaluation. The delta gap, also called as delta delta, is used to identify whether two metabolic disorders are present at the same time. It is important to remember that the delta gap is used only in cases of high anion gap metabolic acidosis, that is HAGMA. It is not applied when the anion gap is normal. The basic concept is simple. We compare the rise in the anion gap with the fall in bicarbonate. This helps us detect a hidden metabolic alkalosis or an additional metabolic acidosis that may otherwise be missed. To calculate it, we first find the delta anion gap, which is measured anion gap minus 12. Then we calculate delta bicarbonate, which is 24 minus the measured bicarbonate level. Comparing these two values allows us to uncover mixed metabolic acid-base disorders. Now that we have validated the ABG and understood the underlying principles, we can move on to interpretation. From this point onward, we will apply the same stepwise approach every time, starting with the pH, identifying the primary disorder, checking compensation, and then looking for mixed acid-base abnormalities when needed. The key is to stay systematic and avoid jumping to conclusions. When you follow the steps in order, ABG interpretation becomes logical and predictable. If the delta anion gap is approximately equal to the delta bicarbonate, this indicates a pure high anion gap metabolic acidosis, that is HAGMA. If the delta anion gap is greater than delta bicarbonate, it suggests a high anion gap metabolic acidosis with a coexisting metabolic alkalosis. And if the delta anion gap is less than delta bicarbonate, it indicates a high anion gap mat acidosis with an additional normal anion gap mat acidosis. This comparison helps us uncover mixed metabolic disorders that may otherwise be missed. The following slides bring the entire ABG approach together into a simple, repeatable flow. We always begin by validating the ABG, checking the relationship between the pH, hydrogen ions, and assessing pF relationship and ensuring internal consistency of the values. Next, we look at the pH and decide whether the patient has acidemia or alkalemia. Once that's clear, we identify the primary disorder, asking whether it's respiratory or metabolic. The next step is to check compensation to see whether it's appropriate or whether a mixed disorder is present. After that, we calculate the anion gap to determine whether the metabolic acidosis is high anion gap or normal anion gap. If needed, we then use the delta gap to look for hidden metabolic disorders. And finally, we always correlate the ABG clinically, integrating the values with the patient's vital signs, history, and other lab findings. Following this sequence consistently makes ABG interpretation logical and reliable. Now let's apply the stepwise approach to a clinical case. This is a 32-year-old male with a history of vomiting for 2 days. He's tachypneic, but his BP is stable. His O2 saturation is 99% on room air. His ABG shows a pH of 7.48, PaCO₂ of 32 and bicarbonate level of 23 and a PaO₂ of 95 millimeters of mercury. Take a moment to go through the steps and try to interpret this ABG before we discuss it further. Let's now go through case 1 step by step. First, we validate the ABG. The PaO₂ is appropriate for room air and the pH correlates well with the hydrogen ion concentration. So the ABG appears valid. Next, we look at the pH. A pH of 7.48 indicates alkalemia. We then identify the primary disorder. The PaCO2 is at low, that is 32, while the bicarbonate is near normal. This pattern points towards a primary respiratory alkalosis. Finally, we assess compensation. In acute respiratory alkalosis, the expected bicarbonate level is approximately 22 to 24, which matches the observed value. This confirms that the compensation is appropriate, with no evidence of an additional acid base disorder. So, the final diagnosis in case 1 is acute respiratory alkalosis. The most likely cause is hyperventilation, which in this patient could be related to pain, anxiety, or vomiting. There are a few important learning points from this case. A normal bicarbonate level does not rule out a respiratory disorder, especially in acute settings. We should always start with the pH, as it sets the direction for interpretation. And finally, looking at the pattern of compensation helps us distinguish between acute and chronic acid base disorders. Applying these principles consistently makes ABG interpretation both reliable and predictable. Let's now move on to case 2. This is a 58-year-old male with a known history of diabetes mellitus who presents with altered sensorium and deep rapid breathing. His ABG shows a pH of 7.12, PaCO2 of 20, bicarbonate of 6, PaO2 of 92. His basic lab values show a sodium of 140, chloride of 100 and a bicarbonate of 6 milliequivalents per liter. Pause here and try to interpret this ABG step by step before we go through the analysis. Let's now analyze case 2 step by step. First, we validate the ABG. The PaO2 is appropriate for room air and the values show good internal consistency. So the ABG is reliable. Next, we look at the pH. A pH of 7.12 indicates severe acidemia. We then identify the primary disorder. The bicarbonate level is very low at 6. PaCO2 is also reduced to 20. This pattern indicates a primary met acidosis. The next step is to check compensation using Venter's formula. The expected PaCO2 is calculated as 1.5 times the bicarbonate plus 8 plus or minus 2, which gives an expected PaCO2 of about 17 plus or minus 2. Actual PaCO2 is 20, which falls within the expected range, indicating appropriate respiratory compensation. Finally, we calculate the anion gap. Using the formula sodium minus chloride plus bicarb, anion gap comes out to be 34, which is clearly elevated, confirming a high anion gap metabolic acidosis. Let's now arrive at the final diagnosis for case 2 using the delta gap. First, we calculate the delta gap by subtracting 12 from the measured anion gap. With an anion gap of 34, the delta gap comes out to 22. Next, we calculate the delta bicarbonate by subtracting the measured bicarbonate from 24. With a bicarbonate level of 6, the delta bicarbonate is 18. When we compare the two, we see that the delta anion gap is greater than the delta bicarbonate. This pattern indicates a high anion gap met acidosis with a coexisting met alkalosis. In this patient, the most likely explanation is TKA, along with a vomiting related met alkalosis occurring at the same time. So the final diagnosis in this case is DKA with a mixed metabolic disorder. This case highlights a few important learning points. Even severe metabolic acidosis can be mixed, and we should never assume a single disorder without checking further. The delta gap is especially useful because it helps unmask hidden metabolic disorders that may not be obvious on initial interpretation. And finally, we should never stop at simply labeling a case as high anion gap metacidosis. Going one step further allows us to make a more accurate and complete diagnosis. Before we wrap up, it's important to highlight some common mistakes in ABG interpretation. One of the most frequent errors is skipping ABG validation. Interpreting an invalid ABG can lead to completely wrong conclusions and inappropriate management. Another common mistake is not starting with the pH. Many learners jump straight to PaCO2 or bicarbonate values, which often leads to identifying the wrong primary disorder. Always remember the pH sets the direction. If you don't start with the pH, the entire interpretation can go off track. Another common mistake is ignoring compensation. Not every abnormal value represents a mixed disorder. If you don't use expected compensation formulas, which may incorrectly label a simple disorder as mixed.
Forgetting to calculate the anion gap is another frequent error. This leads to labeling all metacidosis as the same and can result in missing important causes such as toxins, lactic acidosis, or decay. Similarly, not using the delta gap means we may miss coexisting metabolic disorders, especially in cases of high anion gap metabolic acidosis. And finally, poor clinical correlation is a major pitfall. ABG values should always be interpreted in the context of the patient's vitals, history, and overall clinical picture. Avoiding these common mistakes makes ABG interpretation more accurate and clinically meaningful. Let's end with a rapid revision of the complete ABG approach. First, always validate the ABG. Check the relationship between pH and hydrogen ions. Assess whether the PaO₂ fits the FiO₂. Ensure internal consistency of the values. Next, look at the pH. A pH less than 7.35 indicates acidemia, while a pH greater than 7.45 indicates alkalemia. Then identify the primary disorder. If the pH and PaCO2 move in opposite directions, the disorder is respiratory. If the pH and bicarbonate move in the same direction, the disorder is metabolic. After that, assess compensation. Decide whether it's appropriate or whether a mixed disorder is present using the expected compensation formulas. The next step is to calculate the anion gap using sodium minus chloride plus bicarbonate and determine whether it's high or normal. If the anion gap is high, use the delta gap to look for hidden metabolic disorders. And finally, always clinically correlate. The ABG numbers must fit the patient's history, vital signs, and overall clinical picture. Thank you for watching. If you found this video helpful, please like, share, and subscribe to the channel. Feel free to comment your toughest ABG cases, and I'll try to cover them in future videos. More ICU basics and simplified critical care content will be coming soon. Take care. Bye bye.